Okay, let's unpack this. We are jumping into a monster of a unit today. I mean, 6 chapters back to back. And they're absolutely foundational for clinical practice, aren't they? Covering, well, everything from a minor upset stomach clear through to life-sustaining nutrition.
It's a huge amount of ground, definitely. But so incredibly important. This deep dive is really our way of giving you a comprehensive shortcut through all this pharmacology, the gastrointestinal system and nutrition. Our goal really is to pull together this massive amount of info on like acid control, bowel function, vitamins, even hematology and specialized feeding. And we're focusing relentlessly on how you use this information, the clinical application and the absolute must-know safety priorities for you as a learner.
Right. And what's the thread that ties all these kind of seemingly different systems together? The sources seem to really hammer home the idea of homeostasis.
Exactly. That's the core theme. The body is always, always fighting for that GI and nutritional balance. And when that balance gets thrown off, maybe it's hyperacidity, which, can often be lifestyle related, or perhaps malabsorption, a more systemic thing. The consequences can escalate fast.
Yeah, it goes from just discomfort to potentially, well, catastrophic medical issues pretty quickly.
That really is the crux of it. When you actually read through the source material, the stakes become crystal clear. You're not just dealing with someone feeling a bit off. You're managing conditions that range from, severe ulcer disease, esophageal damage,
Right.
all the way to chronic issues like B12 deficiency, which, and this is critical, can cause irreversible neurologic damage. So being able to safely manage these drug classes is just non-negotiable.
Okay, so structure-wise today, we're going to try and follow the body's logic, right? We'll kick off with GI regulation, think acid control, motility, then pivot to core nutrition and hematology, the essential building blocks, how they connect to blood health. And finally, we'll wrap up with specialized nutritional support. And all the way through, we'll be weaving in those crucial nursing process steps.
Because knowing the drug is one thing.
But knowing the safety check, the assessment you must
Yeah.
do, that's the other half of the battle. Absolutely. Okay, let's start where most people start when they feel GI distress. Gastric hyperacidity. Too much stomach acid. Now, your stomach needs acid, hydrochloric acid, HCl. It maintains a really low pH, like between 1 and 4. It's vital for digestion, obviously, but also critically for killing off bacteria and pathogens that you ingest. But when the stomach produces too much, or maybe the sphincter at the top isn't working right, that's when we see acid reflux, GERD, and eventually peptic ulcer disease, PUD.
And to treat this effectively, we really have to understand the factory producing that acid, right? The parietal cell. That seems to be the main target for a lot of these drugs. Can you walk us through how that acid production actually happens so we know what we're aiming for? Sure. Think of the parietal cell as this little acid factory right in your stomach lining. And the factory gets switched on by several triggers, often hitting all at once. Things like food itself, especially fatty or spicy stuff. Also caffeine, chocolate, alcohol. And importantly, emotional stress is a big trigger too.
Oh, okay.
Now, the cell has sort of 3 main receiving docks or receptors for these go signals. There's one for acetylcholine, one for histamine, and one for gastrin.
So if someone's like grabbing an espresso during a really stressful meeting.
Bingo! You could have all 3 signals blasting the cell saying, make more acid. Now, once those signals arrive, they all kind of funnel down and activate the main piece of machinery inside the factory. And this is key, the proton pump. Technically, it's the hydrogen-potassium ATPase pump. This pump is the final common pathway. No matter the initial signal, this pump does the work. It actively pushes hydrogen ions, protons out of the cell and into the stomach lumen. That's where they form HCl. So if we can block any of those initial receptor signals, or if we can just shut down the proton pump itself, we stop the acid.
Makes sense. Let's start with the simplest approach then, antacids. These don't shut down the factory, do they? They just clean up the spill afterwards.
That's a good way to put it. Antacids are basic compounds, usually salts of aluminum, magnesium, calcium, or sodium. They work through simple chemistry. They neutralize the acid that's already in the stomach, so you get pretty rapid relief. They also seem to have a secondary benefit promoting the stomach's own mucosal defenses. They stimulate mucus, bicarbonate prostaglandins, creating a sort of protective layer.
Okay, but as soon as you mention those different salts, aluminum, magnesium, calcium, you hit that classic nursing pearl, the battle of the bowels. This seems like a really high-yield point.
It absolutely is. This is one of those core memory tricks for this unit. You have to link the salt to the predictable GI side effect, Magnesium salts, think milk of magnesia, are osmotic. They draw water in, famously cause diarrhea.
Right.
On the flip side, aluminum salts and calcium salts, they tend to be constipating. They can sort of slow things down. That's why you see so many combination products over the counter mixing aluminum and magnesium hydroxides. They're trying to balance those opposing GI effects while still neutralizing acid.
But it's not just about the GI effects, is it? The contraindications based on these salts are systemic and really crucial, especially considering the patient's other health issues.
Critically important. These aren't just local gut issues. Magnesium must be avoided in patients with renal failure, full stop. Why?
Right.
Because healthy kidneys are needed to excrete excess magnesium. If the kidneys aren't working well, magnesium builds up fast. That leads to hypermagnesemia, which causes CNS depression, loss of reflexes, serious problems.
Okay.
And then there's sodium bicarbonate, another antacid. High risk for systemic alkalosis, making the whole body too alkaline. Plus, it's loaded with sodium. So it's a definite no-go for patients with hypertension, heart failure, or, again, renal insufficiency. You're adding a huge sodium load.
And there are a couple of other risks with using antacids long-term, right?
Yeah.
Rebound and something called milk alkali syndrome.
Yeah. Rebound hyperacidity is basically the body overcompensating. You rapidly neutralize the acid, and when the antacid wears off, the stomach cranks up production even higher for a bit. Milk alkali syndrome is rarer, but serious. It happens with chronic high-dose intake of calcium antacids, especially if someone's also drinking a lot of milk and has some renal issues. Leads to dangerously high calcium levels, hypercalcemia.
Okay, moving up the ladder in terms of potency. We get to the H2 receptor antagonists, the H2RAs, things like famotidine, cimetidine. These block one of those initial signals at the parietal cell.
That's right. They specifically and competitively block the histamine H2 receptor, and histamine is probably the strongest signal telling that parietal cell to fire up the proton pump. So by blocking that H2 receptor, the cell becomes way less responsive to all the stimuli, histamine, ASHI, gastrin. The result is pretty significant acid inhibition, sources say up to 90%. But importantly, this blockade is reversible.
They're used a lot for GERD and PA, and the sources also highlight their use in stress ulcer prophylaxis. Why is that so important in, say, an ICU setting?
That's a really key application. In patients who are critically ill, think ICU, major surgery, trauma, the physiological stress itself can cause small erosions or ulcers to form in the stomach or duodenum. Sometimes within 24-48 hours, these can bleed, sometimes massively. So using an H2RA or sometimes a PPI, prophylactically, preventatively, is standard practice to stop potentially life-threatening GI bleeds while the patient is recovering from whatever else landed them in the ICU.
Gotcha. Adverse effects seem generally low, but there are a few things nurses need to watch for, especially in certain populations.
Yeah, the overall incidence is low, less than 3% report issues, but vigilance is key. Particularly in older adults, you sometimes see CNS effects, confusion, maybe disorientation. So that's something to monitor. And then there's that classic pharmacology factoid tied specifically to cimetidine, which isn't used as much now because it has more drug interactions.
Right.
But cimetidine can interfere with how the body handles estrogen, potentially leading to impotence and gynecomastia, breast enlargement in men.
Okay. Now, for the real heavy hitters, the proton pump inhibitors or PPIs, omeprazole, lansoprazole, pantoprazole, these names are everywhere. They shut down the whole assembly line, don't they?
They really do. They're incredibly effective because they target that final essential step, the proton pump itself. And crucially, they bind irreversibly to the pump.
Irreversibly. So what does that mean exactly?
It means that specific pump molecule is permanently disabled. It's out of commission for its entire lifespan. To get acid production back from that specific pump, the body literally has to synthesize a whole new proton pump protein. This leads to profound acid suppression, often over 90% reduction, lasting a full 24 hours from a single dose.
Wow. And this almost complete shutdown leads to a state called achlorhydria, right? Basically a stomach temporarily without acid. And this seems to be where the significant long-term safety concerns really start to surface. If you take away that primary defense, what happens?
Well, you essentially open the door for things that shouldn't get through. The sources are very clear about the major safety red flags with chronic, long-term PPI use. First off, that strong acid environment is crucial for killing ingested bacteria. If the acid's gone, bacteria have a much easier time surviving passage through the stomach and reaching the intestines. This significantly bumps up the risk for serious GI tract infections, most notably Clostridioides difficile, or C. diff, which can cause severe, potentially fatal diarrhea.
And then there's the big one related to bone health. That gets mentioned a lot.
Yes, this is clinically crucial. Long-term PPI use is associated with an increased risk of osteoporosis and fractures, particularly hip, spine, and wrist fractures. The exact why is still being debated, but the leading theories involve impaired absorption of especially calcium carbonate supplements, which need acid, or perhaps interference with osteoclast function, the cells that break down bone. Regardless of the mechanism, the FDA has issued warnings. So, for patients on these drugs for years, you absolutely need to consider their bone health, maybe assess risk factors or bone density.
And we'll circle back to this, but doesn't this tie into potential B12 deficiency as well? Which brings us right back to that parietal cell doing double duty.
It absolutely does. The parietal cell isn't just about acid. We'll get into that more with vitamins, but yes, suppressing its function has ripple effects far beyond just the stomach pH. It's a perfect example of the unit's interconnectedness.
Okay, this feels like a good point to bring up a fundamental rule that seems to pop up again and again in these chapters. Managing drug interactions through careful timing, that 1 to 2 hour separation rule.
Yes. This is paramount. If you take a drug that changes the stomach pH, like an antacid or H2RA, or one that contains minerals that can bind things up, like calcium or iron, you are fundamentally going to mess with the absorption of many other oral medications taken around the same time. Antacids are notorious for this. They can reduce the absorption of digoxin, thyroid hormones, and especially certain antibiotics. The rule is strict. You must separate antacid administration from these other drugs by at least 1 to 2 hours.
Let's really emphasize the risk with antibiotics, particularly the quinolones, like ciprofloxacin. That sounds like a recipe for disaster.
It really is a setup for therapeutic failure. Imagine your patient has a serious infection, a nasty UTI, maybe pneumonia, and they're prescribed Cipro. If they take an antacid, say, within an hour of their Cipro dose, the sources show that antibiotic absorption can plummet by more than 50%.
Wow.
They're effectively getting half the intended dose. That could easily lead to the treatment failing, the infection getting worse, and potentially promoting antibiotic resistance. This is a critical patient education point for nurses.
Absolutely. And there's another major interaction highlighted, PTIs, specifically omeprazole, and the antiplatelet drug clopidogrel.
Yes, another really significant one. Omeprazole is known to inhibit a specific liver enzyme called CYP2C19. Why does that matter? Because clopidogrel Plavix, which is used to prevent blood clots, strokes, heart attacks, is a prodrug. It needs that exact enzyme, CYP2C19, to be converted into its active form that actually prevents clots.
Ah, I see.
So, if omeprazole is inhibiting the enzyme, the clopidogrel doesn't get activated properly. It doesn't work as well. This significantly increases the patient's risk of having a major cardiovascular event like a heart attack or stroke, despite being on the medication. That's why other PPIs, or different acid reducers altogether, are often preferred for patients who absolutely need clopidogrel.
Okay, shifting gears now. We've dealt with the chemical environment of the stomach. Now let's move down to the mechanics of the lower GI tract. Chapter 51 tackles bowel function control, primarily constipation and diarrhea. And laxatives. Well, they're probably one of the most commonly self-prescribed over-the-counter drug classes, right? Which leads to issues like dependence and misuse.
Definitely. The sources group laxatives into 5 categories, based entirely on how they work physically to move things along. Let's start with the one that mimics natural fiber, bulk-forming laxatives. Right. Bulk-forming agents like psyllium, metamucil, or methylcellulose work by absorbing large amounts of water. They swell up in the gut, forming this soft, gel-like mass. This increased bulk basically stretches the bowel wall, mimicking a large meal, and stimulates peristalsis, the natural wave-like contractions, through reflux. The absolute key safety point here is administration. You must tell patients to mix the powder with a full glass, at least 8 ounces of liquid, and drink it immediately.
Immediately. Why the rush?
Because if you let it sit, it starts to thicken and congeal right there in the glass. If they swallow it partially congealed or don't drink enough fluid with it, that mass can actually obstruct the esophagus or throat. You're essentially creating cement if you don't take it properly.
Yikes. Okay. Next up, we have emollients and then the osmotic agents.
Emollient laxatives are basically stool softeners, like Docusit sodium, Coles. They work by letting water and fats penetrate the stool, making it softer and easier to pass. They don't really stimulate the bowel much. Then you have the hyperosmotic agents like polyethylene glycol, Miralax, or Lactulose, and the saline laxatives, which are usually magnesium salts like magnesium citrate or hydroxide. Both of these work by increasing the osmotic pressure inside the bowel. They pull large amounts of water and electrolytes into the intestinal lumen. This watery influx distends the bowel and triggers evacuation.
Those saline laxatives sound pretty potent, maybe even high risk for just routine constipation.
They are definitely potent and work quickly. They're often used for bowel prep before procedures, but yes, they carry a significant risk of causing severe dehydration and electrolyte imbalances. This is particularly dangerous in older adults or anyone with kidney issues. And notice we're back to magnesium salts. So that same renal safety check we discussed for magnesium antacids applies here too. Magnesium toxicity is a recurring theme we need to watch.
That specialty use of lactulose you mentioned is fascinating. It shows how a drug's mechanism can be leveraged for something completely different than its primary use, right? It's not just for constipation.
Exactly. Lactulose is a synthetic sugar that our bodies can't digest until it reaches the colon. Once there, bacteria metabolize it, breaking it down into acids like acetic and lactic acid. This makes the colon environment acidic. And here's the clever part. That acidic environment traps ammonia, NH3, which is toxic, especially to the brain. It converts the ammonia into ammonium ion, NH4+, which is not absorbed back into the bloodstream and gets excreted in the stool.
So it lowers blood ammonia levels.
Precisely. This mechanism is used specifically to treat or prevent hepatic encephalopathy, a serious complication of liver failure where ammonia builds up and affects brain function. The goal isn't just a bowel movement, it's usually titrated to achieve 2 to 3 soft stools per day to ensure continuous ammonia removal.
Very interesting. Okay, and the last category. Stimulant laxative, senna, bisacidil. These sound like the most, well, aggressive.
They are, because they work by directly irritating or stimulating the nerve endings in the intestinal wall. This triggers strong peristalsis. While they're effective for acute constipation relief, they carry the highest risk for developing dependence. The bowel can become reliant on that artificial stimulation. Long-term, daily use can lead to what's called cathartic colon, where the bowel loses its natural muscle tone and ability to function properly without the stimulant. Plus, they can cause cramping and nutrient malabsorption. We really need to counsel patients against chronic use.
Okay, let's flip the coin to antidiarrheals. When things are moving too fast, we often look towards opiates or related drugs like loperamide, Imodium.
Right. Opiates and related drugs work by decreasing GI motility. They slow down the propulsive movements of the intestine, allowing more time for water and electrolytes to be absorbed back into the body from the stool. Loperamide is widely available. Another one, difenoxylate, is often combined with atropine in a product called Lomotil. This combination has a specific safety feature.
The atropine is there to discourage abuse, isn't it?
Exactly. Difenoxylate itself is an opioid derivative, so there's potential for abuse at high doses. The atropine is added in a very small subtherapeutic dose. If someone tries to take a large amount of Lomotil to get high from the difenoxylate, they'll also get a nasty dose of atropine, causing really unpleasant anticholinergic side effects: dry mouth, blurred vision, urinary retention, flushing. It acts as a deterrent.
Clever. What about adsorbents like bismuth subsalicylate, Pepto-Bismol? How do they work?
Adsorbents work by coating the walls of the GI tract. They also bind to causative bacteria or toxins, essentially trapping them and preventing them from being absorbed or irritating the gut lining.
The key safety caution here is the subsalicylate part. Salicylate is related to aspirin.
Therefore, bismuth subsalicylate should be used with extreme caution or generally avoided in children and teenagers who are recovering from chickenpox or the flu. This is because of the risk of Ray's syndrome, a rare but potentially fatal condition causing brain swelling and liver damage linked to aspirin salicylate use during viral illnesses in kids.
That's a critical point.
Okay.
And we should also mention the color change it causes, right?
Yes, definitely prepare patients for that. It commonly turns the tongue and stools black or dark gray. It's harmless, just unabsorbed bismuth, but it can be alarming if they aren't expecting it. Might make them think they have GI bleeding.
Okay, moving on to Chapter 52, antiemetics and anti-nausea drugs. Vomiting is such a complex reflex involving multiple pathways. It makes sense we'd need different types of drugs to block it.
Absolutely. The control system involves two main areas in the brain: the vomiting center, VC, and the chemoreceptor trigger zone, CTZ. These centers receive nausea signals from various places. The GI tract itself can send signals if it's irritated. The cerebral cortex can trigger nausea due to things like stress, anxiety, foul sights or smells, or even anticipation, like with chemotherapy. And the labyrinth, the balance center in the inner ear, sends signals that cause motion sickness. Our antiemetic drugs work by blocking the specific neurotransmitters like acetylcholine, histamine, dopamine, serotonin, substance P that carry these signals along those different pathways.
So which drug classes are best suited for, say, motion sickness? That seems to involve that inner ear pathway.
For motion sickness, you want drugs that primarily block signals from the labyrinth. That's where the anticholinergics, like scopolamine, and the antihistamines, like meclizine or dimenhydrinate, dramamine, really shine. They're very effective because they target those specific acetylcholine and histamine receptors involved in processing balance and motion signals. Scopolamine patches are a classic example for preventing motion sickness on cruises or long drives.
Okay. But when we're dealing with really severe nausea, like chemotherapy-induced nausea and vomiting, CIV, we usually reach for the serotonin blockers, like ondansetron.
Yes, ondansetron, Zofran, and related drugs, cetrons, are the workhorses for CINV and also postoperative nausea and vomiting, PONV. They work by blocking the 5-HT3 serotonin receptors, which are found in the GI tract, the CTZ, and the VC. So they hit multiple points in the nausea pathway triggered by chemo or surgery. The key thing for clinical practice, especially with highly immunogenic, nausea-inducing chemotherapy, is timing. These drugs work best preventatively. You need to administer them 30 to 60 minutes before the chemotherapy infusion starts. If you wait until the patient is already feeling sick, they're far less effective.
That makes sense. Now, metoclopramide, Breglin, is interesting. It's a prokinetic, meaning it speeds up gastric emptying, but it also acts as an antiemetic by blocking dopamine. But it comes with a significant warning, doesn't it?
It does. Metoclopramide's dual action is useful in situations like diabetic gastroparesis, delayed stomach emptying, or certain types of acute nausea. It blocks dopamine receptors in the CTZ. However, it carries an FDA black box warning regarding the risk of developing tardive dyskinesia with long-term or high-dose use.
And tardive dyskinesia is?
It's a serious, potentially irreversible movement disorder characterized by involuntary, repetitive movements, often involving the face, tongue, or limbs. Because of this risk, metoclopramide use is generally recommended only for short-term therapy, less than 12 weeks, or when other antiemetic options haven't worked or aren't appropriate.
Good to know. Before we leave antiemetics, there's a crucial nursing safety alert about how not to give hydroxyzine.
Yes, absolutely vital. Hydroxyzine is an antihistamine sometimes used for nausea or anxiety. It must never be administered intravenously. Giving it forward can cause severe tissue damage, thrombosis, clotting, and even gangrene. It should also not be given intra-arterially or subcutaneously. The recommended routes are oral or deep intramuscular IM injection. This is one of those absolute never-ever rules in medication administration. Hashtag TAC3, Core Nutrition and Hematology, chapters 53 and 54. Okay, now we shift focus a bit. We've talked about regulating the GI system's function. Now let's talk about what the body actually needs from that system, the essential building blocks, vitamins and minerals from chapter 53, and then how we deal with issues like anemia in chapter 54. We generally categorize vitamins based on their solubility, which directly impacts how they're stored and the risk of toxicity.
Right. We have the fat-soluble vitamins A, D, E, and K. These get stored in the body's liver and fatty tissues, which means if you take way too much, they can build up to toxic levels, a state called hypervitaminosis.
Exactly. Contrast that with the water-soluble vitamins, the B-complex vitamins, and vitamin C. These generally aren't stored long-term. Excess amounts are readily excreted in the urine. So you typically need more consistent daily intake of these. Deficiency can develop faster, but toxicity is less common unless taking massive doses.
And you mentioned massive doses. The sources talk about megadosing. What's that about?
Right. Megadosing is when vitamins are given in doses far, far exceeding the normal dietary requirements, maybe 50 or 100 times higher. At these levels, they stop acting simply as nutrients and essentially function as drugs, pharmacologically targeting specific conditions. For example, high-dose niacin, vitamin B3, is used as a medication to help lower cholesterol and triglycerides. Vitamin B6 is given in high doses to prevent neurological side effects from the tuberculosis drug isoniazid, which depletes B6. These aren't just more is better, they are specific drug therapies with potential side effects that need monitoring just like any other medication.
Okay, let's circle back to that connection we hinted at earlier, the parietal cell and vitamin B12. This really seems to tie the unit together.
It absolutely does. This is probably one of the most elegant synthesis points in these chapters. Vitamin B12, or cyanocobalamin, is absolutely essential. We need it for healthy nerve function and for producing red blood cells. But here's the catch. To absorb B12 from our food in the small intestine, we need a special protein called intrinsic factor. And where is intrinsic factor made? It's secreted by those very same parietal cells in the stomach lining that produce hydrochloric acid.
Wow, okay. So if the parietal cells are damaged or not working well, maybe due to age or stomach surgery like bariatric surgery, chronic alcoholism, or...
Yeah.
And here's the link. long-term use of acid-suppressing drugs like PPIs or H2 blockers.
Then intrinsic factor production goes down.
And if there's no intrinsic factor.
You can't absorb dietary B12 effectively even if you're eating plenty of it.
And the consequence of that deficiency is pretty severe.
It is. Chronic B12 deficiency leads to a specific type of anemia called pernicious anemia and also GI lesions. But the most dangerous and insidious consequence is the irreversible neurologic damage. B12 is vital for maintaining the myelin sheath around nerves. Without it, you get demyelination. This leads to symptoms like numbness, tingling in the hands and feet, balance problems, ataxia, confusion, memory loss. And once that nerve damage occurs, it's often permanent. You're not just fixing a blood count, you're preventing permanent brain and nerve injury.
That makes the warning about folic acid incredibly important then. The masking danger.
Critically important. Folic acid, vitamin B9, is also needed for red blood cell production. If someone has anemia caused by B12 deficiency, giving them high doses of folic acid can actually make the blood count look better. It can correct the anemia itself.
So it masks the problem.
Exactly. It masks the hematologic sign of the B12 deficiency, making you think the problem is solved. But meanwhile, the underlying B12 deficiency persists, and the neurologic damage continues silently and irreversibly. That's why the absolute rule is you must never use folic acid alone to treat macrocytic anemia, anemia with large red cells, until you have definitively ruled out an underlying vitamin B12 deficiency. You have to check the B12 level first.
Okay, point taken. Let's shift to minerals, focusing on calcium, the most abundant one, and its interaction risks.
Calcium is obviously key for bones and teeth, muscle function, nerve transmission. We need vitamin D to absorb it efficiently. The major drug interaction alert with calcium is chelation. This is a chemical process where calcium ions bind directly to certain other drugs in the GI tract. Particularly notorious are the tetracycline and quinolone antibiotics. Calcium binds them up, forming an insoluble complex that just passes right through the gut without being absorbed.
So the antibiotic becomes useless.
Pretty much. It renders the antibiotic therapeutically inactive. So if your patient needs, say, ciprofloxacin and a calcium supplement, or even calcium-rich antacids or dairy, they absolutely must separate the doses by 1 to 2 hours. There's that timing rule again. Also, a side note, if a patient has high calcium levels, hypercalcemia, and is also taking digoxin for heart failure, the risk of serious cardiac dysrhythmias goes way up. Calcium affects heart muscle contractility.
Okay, and magnesium, we've seen it as an antacid and a laxative, now as an essential mineral.
Right. Magnesium is vital for hundreds of enzyme systems, nerve function, muscle contraction. Therapeutically, IV magnesium sulfate is used to treat conditions like eclampsia during pregnancy or sometimes preterm labor. But we have to circle back again to the risk of toxicity. Hypermagnesemia, especially, as always, in patients with poor renal function. The signs of magnesium toxicity are progressive. First, loss of deep tendon reflexes, then drowsiness, lethargy, muscle weakness, eventually leading to severe CNS depression, respiratory distress, and cardiac arrest.
Is there an antidote if toxicity occurs?
Yes, thankfully. The immediate antidote for severe magnesium toxicity is intravenous calcium gluconate. Calcium directly counteracts magnesium's effects at the neuromuscular junction.
Good to know. Moving into Chapter 54, anemia drugs. Let's start with the erythropoiesis-stimulating agents, ESAs, like epoetin alpha, Procrit, Epigen.
ESAs are basically synthetic versions of erythropoietin, the natural hormone produced mainly by the kidneys that tells the bone marrow to make more red blood cells. They're incredibly valuable for treating anemia associated with chronic kidney disease, because failing kidneys don't make enough erythropoietin, or anemia caused by certain cancer chemotherapies. However, 2 absolutely critical points. First, ESAs are completely ineffective if the patient doesn't have adequate iron stores. You need iron to build hemoglobin, which goes inside the red blood cells. So patients on ESAs often need concurrent iron supplementation. Giving ESA without iron is like sending blueprints to a factory with no raw materials.
Okay, makes sense. And the second point, the black box warning.
Yes, this is serious. Clinical trials showed that using ESAs too aggressively, pushing the hemoglobin levels too high, actually increased the risk of serious cardiovascular events. Specifically, aiming for hemoglobin above 11 GDL in cancer patients, or consistently above 10 or maybe 11 GDL in renal patients, was associated with a significantly higher risk of heart attack, stroke, blood clots, thrombosis, and even death. So these are powerful drugs, but they must be dosed carefully to reach a specific conservative target hemoglobin range, not necessarily a normal level. It's about relieving symptoms, not normalizing the number at all costs.
Understood. Now, iron products. The sources highlight a truly alarming safety issue here, especially with kids.
Yes, this is just tragic and preventable. Iron overdose is cited as the most common cause of pediatric poisoning deaths in the U.S., primarily because many common adult-strength enteric-coated iron supplement tablets look like small, dark candies. A curious toddler finds the bottle, thinks it's candy, and ingests a potentially lethal dose very quickly. Iron is highly toxic in overdose. From a nursing perspective, this demands extreme emphasis on safe storage, keeping iron supplements locked away, out of sight and reach of children, and thorough education for families.
Beyond that critical safety point, how can we help patients take iron effectively? Absorption can be tricky, and GI upset is common.
Right. Oral iron is best absorbed in an acidic stomach environment, so taking it with vitamin C, like a glass of orange juice, can enhance absorption. Conversely, things that reduce acidity, like antacids, or things that bind iron, like milk or calcium supplements, will decrease absorption. So again, timing and separation are key. GI side effects like constipation, nausea, and stomach cramps are common. Taking it with food can sometimes help, although that might slightly reduce absorption, and you absolutely must educate the patient to expect their stools to turn black or dark green. This is normal, it's just unabsorbed iron, but they need to know so they don't panic thinking it's blood. However, you still need to differentiate this from actual melena, sticky, black, tarry stools from digested blood.
What about when oral iron isn't enough or not tolerated? Parenteral iron.
Yes, IV or IM iron can be used. The main thing to remember, especially with older formulations like iron dextrin, is the risk of anaphylaxis. It's relatively low but serious when it happens. Because of this, a small test dose is often required before giving the full therapeutic dose of iron dextrin, and you must have resuscitation equipment readily available whenever administering parenteral iron. Newer formulations might have a lower risk profile, but caution is always warranted. #tag 4V. Specialized nutritional support. Chapter 55. Okay, our final major topic takes us into specialized nutritional support for patients who just can't eat enough or anything at all to meet their body's needs. Chapter 55 covers this. The big decision point is, can we use the gut or not? This leads to two main routes: enteral nutrition, EN, which uses the GI tract, and parenteral nutrition, PN, which goes intravenously. The guiding principle is always, if the gut works, use it. Enteral nutrition is preferred whenever possible.
Why is EN preferred?
Several reasons. It helps maintain the normal structure and function the integrity of the gut lining. This barrier function is important for preventing bacteria from translocating from the gut into the bloodstream. EN is also generally safer, associated with fewer serious complications, especially infections, compared to PN, and it's usually less expensive. Formulations vary. There are elemental, pre-digested, polymeric, standard, whole nutrients, and modular types chosen based on the patient's digestive capacity and needs. Delivery can be oral if possible, or more commonly via feeding tubes, nasogastric, gastric, jejunal.
But even though EN is preferred, tube feeding isn't without risks, right?
Definitely not. The most common adverse effect is probably GI intolerance, things like diarrhea, cramping, bloating. This often relates to the formula type, the rate of infusion, or maybe contamination. Rapid infusion, especially of large volumes, bolus feeds, into the stomach, can cause dumping syndrome, rapid fluid shifts causing dizziness, sweating, nausea, diarrhea. And critically, any patient receiving tube feeding is at risk for aspiration pneumonia. If formula backs up from the stomach and gets into the lungs, it can cause a nasty infection. Keeping the head of the bed elevated during and for a period after feeding is a standard preventative measure.
And here it is again. We need to talk about drug interactions and timing with tube feeds.
Yes, that 1 to 2 hour rule makes another appearance. The enteral feeding formula itself is a complex mixture. It can physically coat the stomach or bind with certain medications, significantly impairing their absorption. It's crucial to hold the tube feeding for at least 1 hour before and 1 hour after administering specific medications. Some sources even say 2 hours. Key drugs affected include phenytoin, Dilantin, and anti-seizure med with a narrow therapeutic window. Reduced absorption could lead to subtherapeutic levels in seizures. Also, certain antibiotics like quinolones, Cipro, and tetracyclines are significantly affected by concurrent tube feeding. This requires careful coordination between nursing, pharmacy, and dietary to schedule medications and feeding times appropriately to ensure both drug efficacy and adequate nutrition.
Okay, so what if the gut doesn't work? If it's not functional due to obstruction, ileus, severe malabsorption, or needs complete rest, like after major surgery, then we turn to parenteral nutrition, basically, also called total parenteral nutrition, TPN.
Exactly. PN bypasses the gut entirely, delivering nutrients directly into the bloodstream intravenously. We can differentiate between peripheral parenteral nutrition, PPN, and central TPN. PPN uses a peripheral vein, like in the arm. It's generally for shorter-term use, less than 2x, and for patients with lower caloric needs. The solutions have to be less concentrated, typically keeping the dextrose concentration below 10%, because highly concentrated solutions are very irritating to smaller peripheral veins. Risk of phlebitis. Central TPN, on the other hand, requires infusion through a large central vein, like the subclavian or internal jugular, via a central venous catheter. This allows for highly concentrated solutions. Dextrose can be 25%, 35%, even up to 50%, delivering a lot of calories and less fluid volume. It's used for long-term support, 7-10 days, or when nutrient needs are very high.
So central TPN allows for higher concentrations, but probably carries higher risks too.
Yes, definitely. Because it requires a central line, there's a greater risk of serious catheter-related bloodstream infections, CRBSIs. And because the solutions are so concentrated, especially in dextrose, there's a significant risk of metabolic complications, primarily hyperglycemia, high blood sugar.
Let's talk about what's actually in TPN. It's more than just sugar water, right?
Oh, absolutely. TPN is a complex, customized mixture. The main components are, 1, amino acids, the building blocks of protein, essential for tissue repair and synthesis. 2, carbohydrates, primarily as dextrose, glucose. This is the main calorie source, providing about 3.4 kilocalories per gram. 3, lipids, fats, usually given as intravenous fat emulsions, IVFE. These provide essential fatty acids and are a very dense calorie source, about 9 kilocalories per gram. Including lipids also helps prevent hyperglycemia by providing non-carbohydrate calories, reducing the total dextrose load needed. Plus electrolytes, vitamins, trace elements, all tailored to the individual patient's needs based on lab work and clinical condition.
Okay, it's complex. What's the single most immediate, life-threatening danger associated with the TPN infusion itself that nurses absolutely must be prepared for?
This is arguably the highest alert situation in this chapter. Rebound hypoglycemia if the TPN is stopped abruptly.
Rebound hypoglycemia. How does that happen?
Think about it. TPN, especially central TPN, delivers a constant high concentration of dextrose intravenously. The patient's pancreas responds by churning out a consistently high level of insulin to handle this continuous sugar load. Now imagine the TPN infusion is suddenly interrupted. Maybe the IV line gets clogged, the bag runs empty unexpectedly, or the central line access is temporarily needed for something else. The high glucose infusion stops instantly, but the patient's pancreas doesn't get the message immediately. It's still producing all that insulin based on the previous infusion rate. So now you have high levels of circulating insulin with no incoming glucose to counteract it. This causes the blood sugar to plummet rapidly and severely.
That sounds incredibly dangerous. What's the mandatory immediate nursing intervention if TPN has to be stopped suddenly?
If TPN infusion is interrupted and cannot be restarted right away, the nurse's immediate action must be to hang an intravenous solution containing 5% or 10% dextrose in water, D5W or D10W, at the same infusion rate the TPN was running at. This provides a temporary source of glucose to buffer that circulating insulin and prevent the patient's blood sugar from crashing into dangerously low territory until the TPN can be safely resumed or adjusted. It's a critical safety net.
Got it. So besides that, key nursing implementation points for TPN are strict monitoring.
Absolutely. Strict monitoring of the infusion rate using an IV pump, regular checks of the central line insertion site for signs of infection, redness, swelling, drainage, monitoring the patient's temperature frequently, fever can be an early sign of infection, and, of course, very frequent monitoring of blood glucose levels, often every 4 to 6 hours initially, to manage hyperglycemia or detect hypoglycemia, plus regular lab work to monitor electrolytes and overall nutritional status, #TAG-V, synthesis, and nursing process priorities.
Okay, here's where it gets really interesting, I think. We've gone through 6 chapters, covered a huge range of drugs and nutritional therapies. And as we did, certain safety checks and nursing considerations kept popping up again and again. They aren't just one-off facts for one drug class. They seem to be recurring patterns that define safe practice across this whole unit.
Absolutely. These recurring themes are the high-yield takeaways. If you internalize these patterns, you're well on your way to practicing safely in this area. The first absolutely non-negotiable pattern is the assessment of renal function. We saw this repeatedly. You simply cannot safely administer magnesium-containing products, whether antacids or saline laxatives, without knowing the patient's kidney function. Magnesium toxicity is the risk. Similarly, vitamin D metabolism and excretion are linked to kidney function. And dosing erythropoiesis-stimulating agents, ESAs, is directly influenced by renal status and hemoglobin targets specific to renal patients. Poor kidney function drastically alters drug accumulation and toxicity risk for multiple agents in this unit.
Okay, pattern 1. Check the kidneys. Pattern 2 seems to be that timing rule we kept mentioning.
Yes, the 1 to 2 hour drug separation rule. We called it the golden rule earlier, and it really is. It connects antacids, iron supplements, calcium supplements because of chelation, and even enteral feedings. Failure to separate these by at least 60 to 120 minutes from crucial medications like quinolone or tetracycline antibiotics, digoxin phenytoin, you risk subtherapeutic levels and treatment failure for the drug that needs to be absorbed properly.
Got it. Pattern 3. Fluids and electrolytes seems central to everything GI.
Definitely. Assessment of hydration and electrolyte status is paramount, both before and after interventions. Before starting potent laxatives, especially saline or hyperosmotic ones, you have to ensure the patient isn't already dehydrated. Giving them can pull massive amounts of fluid into the bowel. And after episodes of severe vomiting or diarrhea, or when managing TPN, you need to constantly monitor for and correct electrolyte imbalances like potassium, sodium, magnesium. Fluid balance is core to GI homeostasis.
Okay. Fourth pattern. Keeping an eye on the brain and nerves.
Right. CNS monitoring is a high priority for several drug classes here. We need to watch for confusion or disorientation, particularly in older adults receiving H2 blockers. We monitor for sedation and dizziness with many antiemetics, as this increases fall risk. But it also includes monitoring for more severe neurotoxicity. The loss of reflexes and respiratory depression signaling magnesium toxicity, the potential for irreversible neurological damage from untreated B12 deficiency, and the risk of tardive dyskinesia with long-term metoclopramide use.
And the final pattern seems related to bleeding.
Yes, monitoring bleeding risk. This involves keeping an eye on PTINR or platelet counts when relevant, especially for patients receiving vitamin K, which promotes clotting but is used to reverse warfarin toxicity, or those at risk due to underlying GI lesions like ulcers, where acid controllers help heal but don't eliminate the underlying risk. We also need awareness of potential interactions that increase bleeding risk, like PPIs potentially interacting with warfarin or clopidogrel, though the mechanisms and clinical significance are complex and sometimes debated. And of course, iron toxicity can cause hemorrhagic gastroenteritis.
It really feels like this whole unit drives home the point that you can't treat just one thing in isolation, can you? Messing with stomach acid, for example, has downstream effects on nutrient absorption and even bone health. These systems are so tightly linked.
That is precisely the final provocative thought I think we should leave you with. Think back to that central player, the parietal cell. It's doing at least two critical jobs simultaneously. It's managing acid secretion for digestion and defense, and it's producing the intrinsic factor needed to absorb vitamin B12, which is essential for neurological health. Now, consider that some of the most commonly prescribed drugs in the world, PPIs, and to a lesser extent now, H2 blockers, are designed specifically to alter the function of this critical cell, often for years on end. When you do that, you are not just treating heartburn, you are fundamentally changing the body's defensive landscape against infection, and you are potentially compromising its ability to absorb essential nutrients, leading down the line to known risks like B12 deficiency and bone loss, and perhaps other unforeseen consequences we don't fully understand yet. So the takeaway isn't just about memorizing drug names, it's understanding that when you intervene in the GI system or nutritional status, you are often changing fundamental physiology. Mastering the details of this unit, understanding those ripple effects, is absolutely essential for safe, effective nursing practice.
That's an incredibly powerful way to synthesize it all. An incredibly comprehensive look at this really essential pharmacology unit. I think the biggest takeaways for everyone listening have to be remembering those long-term PPI risks, infection, fractures, B12, the very real, very serious pediatric danger of iron poisoning, knowing the critical intervention for TPN rebound hypoglycemia, get that D5W or D10W hanging immediately, and hammering home that 1 to 2 hour dosing separation rule for so many of these interactions. Mastering these points will genuinely serve you well in pretty much any clinical setting you find yourself in. Thank you so much for diving deep into all these sources and concepts with us today. Go forth and use this knowledge safely and effectively.